Hello to all of you. I am Dr. Vishnu. So today I am going to talk about sleep-wake disorder. So this is actually a therapeutics perspective, but I didn't write it as a therapeutics perspective because anyways, if anybody who is interested in medicine, who is interested in clinical pharmacy, or if you are an M-Pharm pharmacy practice, or if you are a PharmD, or anybody who is interested in learning about diseases and medicines, if you watch this presentation, it may feed you with loads of practical knowledge and definitely a lot of things in the background I'll be talking as well. So today we'll talk about sleep-wake disorders. There are different types of the same. We have insomnia, we have narcolepsy, lot of types are there. So we'll talk about them. What are the different causes and what are the different treatment strategies that we can think about sleep-wake disorders. So we'll talk in a summary. So if you appreciate my efforts, because all of these are free of cost, as I have said before, I'm not going to charge any money for anyone from anyone for this. So if you appreciate my efforts, then please do subscribe and share it to maximum people, because knowledge is power and knowledge shared is knowledge doubled. So let's go into the presentation. So first we will talk about the sleep cycle. So many of you use smart bands. Even I am using a smart band. They are also in my smart band when it is connected to the Bluetooth. And then, it shows deep sleep, REM sleep, deep sleep continuity. A lot of technical terms are there. Anyways, these are all terms which have been formulated by the WHO. So we'll talk about the sleep cycle first. And then we will go into individual disorders and how the sleep cycle is affected by those disorders. We will talk in detail. So when a person falls asleep, usually actually that is a theory that when you are asleep, it takes minimum 40 to 45 minutes for you to actually go into deep sleep. Now it is, that time frame may vary, because it depends on what activity you were doing before you were sleeping. Like, many people are there who suffer from insomnia. They stay awake for long periods. So they are usually advised that don't engage in any kind of activities which increases your adrenaline before you sleep, or you don't watch any kind of things, maybe any kind of visuals which actually activates your adrenaline, either makes you emotional or makes you feel aggressive or angry. All these things have an impact on your sleep quality. And definitely the light that is emitted from the electronic devices, they also have a significant negative role to play. So definitely that will definitely affect the quality of your sleep. And that is why when many people wake up in the morning, even if they have slept for 9 to 10 hours also, even if they have slept for 9 to 10 hours also, they are drowsy throughout the day. So why are they drowsy? So that means the concentration of light sleep had been more, the concentration of deep sleep had been less, and even if they had been in deep sleep, the continuity of deep sleep had been very less. So there are a lot of things we have to take into consideration. Sometimes we also take into consideration the amount of caffeinated beverages that you consumed before you slept. What was the time that you had your dinner, because food takes time to digest. So that time also the body becomes active. And immediately if you go into bed, you will not feel sleepy easily. So a lot of things are there which will actually determine the quality of your sleep. And definitely please remember, sleep is very important. If you sleep less, your brain neurons will keep on getting damaged. You may not understand it now, but later you will definitely understand when you get a lot of chronic diseases. So please make sure that you have a minimum good quality sleep, because it doesn't matter. The duration actually doesn't matter. Anyways, minimum you should sleep for 6 to 7 hours, but the duration doesn't matter. Even if you sleep for 12 hours also, but if the quality is not good, you can assure yourself that you will remain tired throughout the day. So sleep is divided into two phases. We have non-rapid eye movement sleep and we have rapid eye movement sleep. So each night, humans experience 4 to 6 cycles of NREM and REM sleep, and each cycle lasts for 70 to 120 minutes. So if you are multiplying like 70 to 120 with into 4 to 6, like for example, each cycle is lasting for 70 minutes and you had 6 cycles of sleep. So 70 into 6 is 420. And if you calculate how many hours 420 minutes it is equivalent to 7 hours. So that is what we usually say that if you are having around 7 to 8 hours or 9 hours of sleep, that is more than enough. But again, I'm saying it should be quality sleep, then you will feel energetic. Now let's come to the sleep cycle regulation in NREM sleep. So NREM sleep again consists of 3 stages. So from wakefulness, the sleep progresses quickly through stages 1 and 2. So when you are, wakeful and suddenly when you go into sleep mode, stages 1 and 2 pass by very fast. So stage 1 is actually the stage between wakefulness and sleep. And at stage 1, individuals describe as being either awake, being drowsy, or being asleep. So that is actually a transition phase between being awake and falling asleep. Stage 2 is not very significant, as I said, that passes by very fast. Stage 3 is very important. So in this stage, what happens? Both the metabolic and brain activities slow down. This sleep actually consists of high amplitude, slow delta waves. So it is also known as delta sleep. So how we understood this is because there are many people who experience epilepsy in their sleep. They have abnormal brain activity. So there is something called sleep EEG, sleep electroencephalogram. So the patient is put to sleep and their brain activities are monitored during the course of the period. So there are, in normal sleep, what happens? There are slow delta waves, and that is why the stage 3 is known as delta sleep. There will be no eye movements. Your eye, the eyeball movements will be completely paralyzed. There will be no eye movements. And definitely there will be no tonic muscle activity. Obviously, when you are in very deep sleep, your body muscles will not move. So obviously, you will be sleeping in one position for a long period of time. Now, when we talk about REM sleep, in this stage, the brain becomes electrically and metabolically activated. So that is characterized by increased cerebral blood flow, generalized muscle atonia. Atonia, always remember, wherever you come across the word A, it means it is negligible or not there. Like aphasia, that means difficulty in speaking. The person is not able to speak. So atonia means there will be no tonicity of the muscle, means the body will not be moving. Poikilothermia, there will be temperature regulation. Obviously, dreaming will be there. So that depends, again, that also depends on what were you thinking while you were about to sleep. Was it positive? Was it negative? What is the impact of a lot of things, matter. And definitely there will be fluctuations in the respiratory rate and in the heart rate. Now we'll talk about the circadian rhythm, which is very important. There are so many people who are working in night shifts, then they suddenly get shifted to the day shift. Those kind of people, they struggle a lot with their sleep pattern. So at birth, human infants spend up to 20 hours a day sleeping with no differentiation. There will be no specific differentiation in their circadian rhythm, because obviously 20 hours a day means a day is 24 hours. We're just minusing 4 from that. So what is it significant? Differentiation between REM and NREM sleep occurs at 3 to 6 months of age. And there is a part of the brain which is known as suprachiasmatic nucleus. So that actually serves as the biological clock, which is also known as circadian rhythm, and that helps in maintaining the same. From childhood into adolescence, the amount of delta sleep reduces and REM sleep increases. So as your age increases, the delta sleep amount reduces and the REM sleep tends to increase. And with increasing age, sleep efficiency and time also reduces. So that is why geriatrics usually have a very hard time, sleeping, although they feel tired most of the time because their body is getting weaker, but still they have a very tough time to actually maintain a good quality sleep. So that happens with increasing age, which is almost quite a normal process. Now let's come to the neurochemistry. NREM sleep is controlled by four things. Now, one is the basal forebrain, hypothalamus, which also regulates your temperature. GABA is an inhibitory neurotransmitter, and adenosine. REM sleep is controlled by cholinergic cells in the medullary and pontine regions, which actually activate, cholinergic cells actually activate REM sleep. And locus ceruleus raphe actually deactivate REM sleep. So both are opposite to each other. So this is just a basic idea for you. If you want to know about what is locus ceruleus and raphe you can refer anatomy and physiology. You'll get to know what it is. Arousal and wakefulness is actually controlled by all these things: posterior hypothalamus, reticular activating system, dopamine, because dopamine makes you alert. Always remember, dopamine makes you alert. That is why when people take CNS stimulants, whether it is any kind of CNS stimulant, it is an additive substance or a non-additive substance, they will have a very difficult time sleeping, especially if you are on amphetamines, you are on phencyclidine, if you are on LSD or any kind of CNS stimulant, means dopamine is activated, and dopamine always makes you alert. So when you are alert, you will always be energetic. Always remember this. When you are alert, you will always be energetic. Noradrenaline also has a role to play in arousal and wakefulness. So if there is noradrenaline excess in your body due to any kind of reason, you can suffer from insomnia. Acetylcholine also has a role to play. So acetylcholine also, to some extent, controls arousal and wakefulness. Histamine, that is quite very simple. It's a very simple common sense. If you have taken antihistamines in your life, let it be cetirizine, let it be levocetirizine, whatever it is, you know very well, you will always feel sedated. So if you take all these antihistamines at daytime, you will always yawn and feel sedated, because histamine makes you alert and antihistamine makes you drowsy. So you can understand very well what is the role of histamine in arousal and wakefulness. Then there is something called substance P. Substance P is actually involved in the pain pathway also. Maybe in the future or something I'll talk about substance P. Then we will talk about the pain pathway and what is the role of that. And definitely CRF in hypothalamus, corticotropin releasing factor in hypothalamus. So these are the different factors which control arousal and wakefulness. So we have actually a lot of kind of sleep disorders. We'll not talk about all of them. This is just for your information's sake. We have insomnia disorder, we have hypersomnolence disorder, we have narcolepsy, we have breathing related sleep disorders, we have circadian rhythm sleep disorders, we have non-REM sleep arousal disorders, we have nightmare disorder. Nightmare disorder is, you know very well, if you suddenly get a very bad dream and you just get up like anything, and then it becomes very difficult for you to actually fall asleep back. REM sleep behavior disorder, restless leg syndrome, that is also a very important factor in determining your sleep. Restless leg syndrome is a condition in which if you are lying on the bed and your legs are continuously moving to and fro, so that also hampers your sleep pattern, because obviously, as I said, that atonia happens, means your body muscles shouldn't move if you are sleeping properly, and if you are having restless leg syndrome, means your sleep quality will get affected. And definitely substance or medication induced sleep disorder. So if you are on CNS depressants, for example, you are addicted to barbiturates, you are addicted to benzodiazepines, all this kind of thing. So definitely you will have insomnia if you withdraw from that, or else you will be hyper sedated if you are addicted to that. And if you are on CNS stimulants, for example, cocaine, if you are addicted to amphetamines, if you are addicted to phencyclidine or something like that, so they are CNS stimulants. So you will have insomnia. But if you suddenly withdraw from that, you will have somnolence, because when you are de-addicted from something which is a CNS stimulant, then definitely you will fall drowsy. Anyways, I'll talk about all this in the toxicology series. I'm planning to, talk about toxicology also. It's very interesting. I have a lot of ideas. Let's see how things go. A lot of, the brain consists of 100 billion neurons. So a lot of ideas keep on coming on the way. Let's see how things go. Anyways. Now let's talk about insomnia. It's the most common sleep disorder. So definitely it is defined as a difficulty in initiating or maintaining sleep. Please remember this. Insomnia is of 2 types. Or maybe you can say it is of 3 types. First type is you are lying on the bed, but you are having difficulty to start the sleep, to initiate the sleep. So that is called initiating problem. Now, for example, you are lying on the bed, you fell asleep, but in between many times you are waking up. So that is called maintenance disorder. That means you are not able to maintain the sleep. And then the third type, which is the most dangerous, that is you are having problem with initiation also, and you are having problem with maintenance also. So that is very dangerous. That means your sleep quality will be completely scattered. So that is why whatever medicines we give for insomnia, it depends on which kind of insomnia you are suffering from. So for example, if you are having problem with initiating sleep, then we give a fast-acting medication. Fast-acting medication means it will show its mechanism rapidly. So if you are having problem with initiating, you take the medicine and lie on the bed and you will instantly fall asleep. If you are having problem with maintenance, then definitely you need a long-acting medication, because you are not having problem with initiation. So you will fall asleep. So this maintenance medication will help to regulate your sleep process. So like that, lot of, interesting matters are there. We'll talk about that. And definitely, if you are having insomnia, I don't need to explain to you. It results in a lot of health problems, reduced work productivity. If you are having insomnia, then it increases the level of cortisol, which is the stress hormone in your body. That can lead to a lot of different types of chronic diseases. So, a lot of things are there. If insomnia occurs for 3 times per week for 3 months, it is considered to be chronic in nature. Now, if you look at the etiology of insomnia, that can be, see, there are so many reasons for insomnia. It is very hard to explain, but just some things have been summarized here. So we have situational causes, we have medical causes, we have psychiatric causes, and we have drug-induced causes as well. Now, if you talk about situational causes, work or financial stress, obviously, that is something everybody are going through right now. Jet lag, if the time range or if the time zone changes, so that can also affect your circadian rhythm, especially if you are going from one country to a very distant country. Shift work, this is very, very important. I personally understand how horrible it is, because I've seen a lot of people who are on night shift and suddenly they are shifted to the evening shift, then they are shifted to the morning shift. So what happens is that the body is not able to acclimatize or get adjusted to the differential shifts that they receive. So obviously they will have problem with sleeping. Now, for example, a person who is not habituated to sleep in the daytime, if they are getting a night shift and they are forcefully, they have to sleep in the daytime, you can imagine how horrible it will be for them. So like that, a lot of issues are there. If we talk about medical condition, there are so many reasons. I don't need to explain much. Like we have cardiovascular reasons, angina pectoris, because obviously if you are having chest pain, angina's clinical symptom is chest pain. So if you are having chest pain, how will you fall asleep? Arrhythmias means it will cause palpitations. So that can also lead to chest pain. So that can also make you sleepless. And heart failure also, because heart failure is a condition in which the pumping capacity of the heart, or the basic feature or the basic functionality of the heart, is compromised. So in that condition also you may have this problem. Respiratory issues also, like if you're suffering from chronic respiratory problems, or if you're having asthma or sleep apnea related means difficult, means you have a sudden shortness of breath during sleep. All this condition can also lead to insomnia. Chronic pain, for example, you're suffering from any kind of arthritis, rheumatoid arthritis, or any kind of condition which is demanding long-term painkillers. For example, it can be a cancer-associated pain, terminal stage cancer. So all this condition can make you insomniac. Endocrine conditions also, because diabetes, hyperthyroidism, that can also make you insomniac. GI problems, for example, GERD, peptic ulcer, but we have other conditions also, irritable bowel syndrome, inflammatory bowel disease. All these conditions can also make you insomniac. Neurology conditions are also there. We have delirium, epilepsy, Parkinson's disease, to some extent Alzheimer's disease also. If you are having schizophrenia, in which dopamine hyperactivity is usually seen, in that condition also your sleep pattern can get damaged. And definitely pregnancy, it's not exactly a medical condition, but pregnancy also, depending on the trimester and the complications, or if the mother is already suffering from any other comorbidity which can complicate the pregnancy. So this all can add up to insomnia related conditions for the mother. Psychiatric conditions are also there. For example, mood disorders, like for example, depression, mania, that can also result in this problem. Anxiety disorders, definitely anxiety means you are overthinking about something. So when you are overthinking or overstressed about anything, that can also lead to insomnia. Substance abuse, alcohol withdrawal, sedative hypnotic withdrawal. Please remember this theory. If you are addicted to a CNS depressant, and if you suddenly withdraw from it, the symptoms that you will be getting will be of CNS stimulation. So CNS depressant, if you are addicted to, that means you will be always sedated. Suddenly, if you withdraw from it, so you will have CNS stimulation. That means insomnia. If you are addicted to a CNS stimulant and you suddenly withdraw from it, then you will be getting the symptoms equivalent to CNS depression. So this kind of patients will be always hypersomnolence or sedated. So please remember this theory. Anyways, I'll be talking about this in toxicology later. So alcohol withdrawal. Alcohol is a CNS depressant. So if you suddenly withdraw from it and if you are addicted to it, that can make you insomnia. Sedative hypnotic, as I said before, benzodiazepines, barbiturates, all these things, if you suddenly withdraw from it, that can make you insomniac. Then obviously there are drug-induced reasons also. Anticonvulsants to some extent can make you insomniac, although most of the anticonvulsants, the side effect is actually sedation, depending on the GABA activity, but there are some that can actually make you insomniac. Central adrenergic blockers, to some extent diuretics. Now this is very, very important. Diuretics can cause insomnia, and that is why if you are giving diuretics to patient, especially loop diuretics, and if that patient is already suffering from insomnia, please counsel the patient to not take the last dose of diuretic after 6 to 7 p.m. in the evening. Because diuretics, what they do is they increase the production of urine. If you are taking a very potent diuretic, for example, you are taking loop diuretics, it can be torsemide, it can be bumetanide, or it can be furosemide. What they will do is they will powerfully increase urine production. And if that patient is a geriatric, or if that patient is a person who is already suffering from insomnia, and if they take the last dose at 9 o'clock, 10 o'clock or something, this diuresis will continue. So they will have to get up in the middle of the night to urinate multiple times. If they are admitted in the hospital, it is not an issue, because there will be a urine tube or something like that. So even if they urinate also, it's not a matter of concern. But if they are at home, that can be a matter of concern. So diuretics can cause insomnia. So in such patients, or if the risk factor is there, then the last dose should be between 5 to 7 p.m., not more than that. SSRIs can also cause, because selective serotonin reuptake inhibitors, they increase the level of serotonin, and serotonin again makes you alert to some extent. So that can keep you insomniac. Steroids, very simple. Steroids actually, activate cortisol. Cortisol is a stress hormone, so that can make you anxiety and all this kind of things, overthinking and all. And obviously, steroids in the long term has been related to psychosis also. So definitely insomnia can happen. And CNS stimulants, I don't need to tell you. Amphetamine, LSD, phencyclidine, cocaine, nicotine to some extent also can make you insomniac. So goals of therapy, I have written here, refer. So I will tell you in very simple terms, what do you mean by goals? Goals of therapy, usually people write a lot of things. The goals of therapy should be very simple. Which disease the patient is suffering from, we have to get rid of it as soon as possible. If it is an incurable disease, then we have to maintain the disease. That is the first point that we should write in goals of therapy. The second point that we should write in goals of therapy is to prevent morbidity and mortality. Now that depends on whether that disease can kill you or not. For example, a patient is suffering from osteoarthritis, and if you are writing to prevent morbidity and mortality, it will be a bullshit concept, because osteoarthritis is never going to kill you. So mortality doesn't. So we have to understand what kind of disease it is, whether it will kill you or not, or whether it will just put you admitted or put you on long-term therapy. So in that condition, only morbidity is enough. The third point that we should write in goals of therapy is to maintain a therapeutic window. Therapeutic window means there should be a balance between the efficacy and safety. Like for example, you are giving a medicine which is highly efficacious, but the side effect is so notorious, the patient cannot tolerate. So what is the point in using the medicine? So in such conditions, we have to balance the efficacy and safety. There is a third parameter also which we should look into, and that is called pharmacoeconomics. Like for example, you are giving a medicine which is extremely good, which is extremely safe, but it is extremely costly. So it depends on whether the patient can afford or not. So we have to balance three things: efficacy, safety, and cost. And definitely the last point is to maintain a good health-related quality of life. This is the way how we should write goals of therapy. So that is why I wrote it here, refer. Actually, I used to teach a lot of students before, so I wrote it refer here. But this is my perspective as in how to write goals of therapy. So we will come to sedative hypnotics. So we have non-benzodiazepine receptor agonist, that is ZALEPLON, ZOLPIDEM, SUVOREXANT. We have short-acting benzodiazepine, for example, TRIAZOLAM. We have intermediate-acting benzodiazepines, ETIOLOGY, TEMAZEPAM. And we have selective melatonin agonist, RAMELTEON. I think there is one more, TAZIMELTEON or something, I don't remember. We have RAMELTEON. So non-benzodiazepine receptor agonists, they bind more specifically to the GABA A receptor, so that can cause sedation. So they are actually excellent choices for sleep onset insomnia. Sleep onset insomnia means you are not getting the initiation for sleep. So in those conditions, we can give non-benzodiazepine receptor agonist. Both S-zopiclone and sustained release zolpidem have reduced abuse potential and long-term efficacy. So it has been found that the abuse potential, what do you mean by abuse potential? Like you will abuse something only when you are addicted to that. Always remember, you will abuse something only when you are addicted to that or your brain considers it as food. So S-zopiclone and sustained release zolpidem have been found to have less risk of addiction. So that is why there is less risk of abuse potential and long-term efficacy. Obviously, when the abuse potential reduces, so the efficacy and safety profile will be good. Short-acting and intermediate-acting benzodiazepines are usually effective for sleep onset insomnia because their onset of action will be fast. So if you take that medicine and lie on the bed, within few minutes, you can expect a good sleep initiation. They are safer than barbiturates because barbiturates are much more dangerous and they are cost effective as well. Benzodiazepines, they bind to GABA receptor, they increase the GABA activity, so it causes sedation. I don't understand why the mechanism of action in conventional pharmacological textbooks that we study is so boring. Like there are some textbooks in which the mechanism of action of benzodiazepine has been shown in pictures, in which we don't understand which ion is going where, which arrow mark is going where. It is like a railway station having multiple platforms and the train driver does not know where to go. So always make sure whenever you study mechanism of action, you study it in the simplest way possible using simple textbooks which actually make a good base. Benzodiazepines are dangerous for elderly. Please remember that. Just like anticholinergics cause sedation. Similarly, benzodiazepines are also dangerous for elderly because the elderly, the body is fragile, the body is weak, especially if it is a female whose menses are over. That means they are on menopause. That means there will be lack of estrogen. That means there will be lack of calcium as well. So this kind of females, if they are on benzodiazepines and if they have a fall, there is a huge risk of fractures and casualties. For males also the same thing, because their also bones will be fragile. They will be also weak. So there is a risk of accidents and falls. So it is not recommended in elderly unless in very severe situations due to the risk of falls. If at all it is used in elderly, you should use it for the shortest time and at the lowest effective dose. Sedatives that have long half-life, they can cause daytime sedation also. So they have a high risk of dependence and abuse. So that is why you should be very careful if you are using any kind of benzodiazepine that has a long half-life. Long half-life definitely means that you will have daytime sedation also. So your brain will get addicted to that very soon. So that can be a matter of concern. Other problems of benzodiazepines include tolerance. So tolerance is also another issue because this has been very commonly seen that if you are taking benzodiazepines and you suddenly stop them, for a long period of time you have taken that, and if you suddenly stop them, your body will start showing withdrawal symptoms. And also tolerance means, actually the main meaning of tolerance is that if you're taking it at a particular dose for a long period of time, a situation will come in which the body will not respond to that particular dose. Then you have to take higher dose, and higher the dose you take, lower will be the efficacy and higher will be the side effects. So that is something that we have to be careful about when benzodiazepines are prescribed to patients. Rebound insomnia can also happen. So this usually happens if you are taking benzodiazepines and suddenly stopping it without doing the tapering. So rebound insomnia can happen, and that can be very dangerous. Then we have some orexin inhibitors. So they actually block a molecule known as orexin. So we have LEMBOREXANT and SUVOREXANT. They are good for patients with difficulties of sleep onset or sleep maintenance. So that is one benefit of this molecule. It is good for people who cannot initiate a sleep, and it is also good for people who cannot maintain a sleep. Then we give selective melatonin agonist also. So that is given for insomnia related to sleep onset. So this is especially for individuals who lack dim light melatonin onset stimulation. Actually, usually what happens is that always remember that the blue light that is emitted from your electronic device is the worst enemy of melatonin. Because melatonin gets activated when everything around you is pitch dark. Okay, there can be some amount of dim light maybe, but when everything around you is pitch dark, melatonin gets activated. So there are a lot of people, what we do is we lie on the bed and then we start scrolling through social media and everything. And if you are already insomniacs, the melatonin will not get activated because of the blue light. Obviously, nowadays in all phones, we have blue light filter and lot of options. But at the end of the day, still, the challenge remains the same. So, the selective melatonin agonists are good for those people who are in pitch dark environment, but still they are not getting a sleep. So in that condition, you can take melatonin agonist. We have melatonin supplements also at different doses. We have 3 mg, 5 mg, 10 mg. 10 mg and all is not required. Even 3 mg is more than enough. So we can take that as well. Ramelteon is the only melatonin receptor agonist which is approved for insomnia, and it is available as a prescription medication. We have Zaleplon. Zaleplon belongs to pyrazolopyrimidine class of sedative hypnotics. It has a rapid onset of action, so definitely you can understand, you can derive a practical knowledge from it. It has a rapid onset of action, means it is good for sleep onset insomnia. It has an ultra short duration of action. So obviously rapid onset of action means the duration of action will be short. So because of these above properties, it is good for sleep onset insomnia and not for sleep maintenance insomnia. It is available in capsule formation. The areas you know very well. It is of benzodiazepines and sedatives. So the areas you can understand by yourself. ZOLPIDEM, it belongs to imidazopyridine class. It has a rapid onset of action. So obviously it has a short duration of action. It is also good for sleep onset insomnia. And there is no risk of residual sedation in the morning. Always remember, short-acting benzodiazepines have an advantage. You will not have that hangover effect in the morning. And that is why we counsel the bystanders of patients who are on benzodiazepines that under no circumstances these people should be disturbed. Because if a patient is under benzodiazepine for insomnia, and if you disturb them in the middle of their sleep, and if their sleep quality doesn't become good, when they get up in the morning, they will become extremely irritable. That is why you see the side effects of benzodiazepines as irritability as well. So irritability usually happens if you have taken a long-acting medication, so you are having sedation in the morning also, which is making you irritable because you want to sleep again. Or maybe because you took a short-acting medication, but due to external factors, your sleep got disturbed. So that will make you aggressive, that will make you irritable, and it will make you angry. So short-acting medications, there is no risk of residual sedation in the morning. We have 2-layered controlled release tablets are available. The outer layer actually induces immediate sleep, and the inner layer maintains the sleep. So this is actually a new formulation for ZOLPIDEM. So we have an outer layer which is an immediate acting molecule, and the inner layer is a maintenance molecule. So this is good. If you are having sleep, if you want to maintain the onset and the maintenance also, this will be good. It is also available in sublingual, oral spray and tablet formulations. Zopiclone belongs to pyrrolopyrazine derivatives. It has a short half-life, so you can understand, I don't need to say again, it is very good for sleep onset insomnia because it has a short half-life. That means it has a rapid onset of action. TRIAZOLAM, it is indicated for short-term insomnia. Please refer the areas, and the most problematic issue is that it has a high risk of amnesia. If you see the side effects of benzodiazepines, you will find a term as anterograde amnesia. Amnesia, all this, you will have memory loss. That is why some of the benzodiazepines, unfortunately, are used as rape drugs, because especially females, if they are going to pubs or any kind of this kind of areas, they are always advised not to take any drinks from unknown people, because there are some benzodiazepines which actually are tasteless, and when they are mixed with those drinks, and if it is given, you will completely become sedated and you will not even know what has happened to you. So there is a molecule like that which is known as TRIAZOLAM. Earlier ketamine was used as a rape drug. Now TRIAZOLAM is also. Anyways, TRIAZOLAM is not used anywhere, but still. So TRIAZOLAM, the problem is that you can have abnormal dreams, and definitely there is a high risk of amnesia. Estrazolam, it has a short onset, slow onset of action. It has a long duration of action. So definitely you understood very well. It is good for sleep maintenance insomnia. So long duration of action means that when the patient wakes up in the morning, they may still feel sedated. So this kind of patients may suffer from irritability and all this kind of things. So that is one problem with this molecule. Temazepam is also effective in sleep maintenance insomnia. So sleep maintenance insomnia means it is a long-acting molecule. Again, long-acting molecule means daytime sedation may be there. So that is also a matter of concern. Ramelteon, it is a melatonin receptor agonist. It activates two types of melatonin receptors, MT1 and MT2, which improves the circadian rhythms. So definitely always remember it is melatonin. So melatonin makes you fall asleep. If your sleep quality is not good, if you got disturbed many times in between your sleep, when you get up in the morning, you can assure yourself that you will be very irritable and you can have headache as well. So that is why if you are taking melatonin supplements which are naturally available in the market, or if you are taking a medication, prescription medication like Ramelteon, please make sure your sleep should not get disturbed by any kind of external factors. Suvorexant, it is an orexin which promotes wakefulness. So this actually blocks the binding of molecules like orexin. Actually, orexin, what happens, it makes you alert, it makes you insomniac. So suvorexant actually blocks the binding of orexin to their receptors. So it blocks the activity of orexin, which helps you to improve your sleep. It is also like, same side effects only, because it is the opposite of wakefulness. So you will feel sedated, you can have irritability. So all these basic things will be there. Lemborexant is also the same as that of suvorexant. Same mechanism. Orexin makes you wakeful, and this molecules will block that orexin, which will make you sedated. Sometimes tricyclic antidepressants are also used, but don't use it directly for insomnia because they require therapeutic drug monitoring and they have a huge range of side effects. Huge means seriously huge range of side effects. So they should only be used in comorbid depression or anxiety. If you are having depression associated insomnia or anxiety associated insomnia, in that condition, you may use tricyclic antidepressants. We can use amitriptyline, nortriptyline, and doxepin to some extent. It's good for sleep maintenance insomnia. If we talk about the side effects of tricyclic antidepressants, it's a huge list. Because it is an alpha-1 receptor blocker, it is a histamine type 1 receptor blocker, and it is a very powerful anticholinergic. So now you can predict what all things can happen if tricyclic antidepressants are used in the long term. If it is blocking the alpha-1 receptor, it can cause postural hypotension. It can cause sexual dysfunction because alpha-1 receptors are present in the prostate gland. So it can cause ejaculation problem and sexual dysfunction. If it is blocking the histamine type 1 receptor, then two things will happen. Number one, it will make you sedated. Number two, it can cause weight gain. If it is having anticholinergic effects, because it is a acetylcholine, muscarinic blocker. So cholinergic or acetylcholine, it increases the secretions of your body. Whatever secretion of your body it is responsible through acetylcholine. Anticholinergic will block all your secretions. So you can have a dry mouth. You can have, if you are not sweating, that can result in fever of unknown origin. It can cause urinary retention, which in the long term can lead to urinary tract infections, especially if you are diabetic, or even not also, it can cause urinary retention. Like that, lot of issues are there. And definitely it will cause constipation also, because diarrhea or fecal movement is also a kind of secretion only. It will block that, so it can cause constipation. So the range of side effects are too huge. And tricyclic antidepressants in the elderly will be a very, very dangerous choice as well. So anyways, I will talk about tricyclic antidepressant poisoning. I'll talk about depression and the treatment strategies. There we will talk about the receptor pharmacology of tricyclic antidepressants. And there are a lot of interesting things that I would like to share you there. Other antidepressants, they actually cause drowsiness as a side effect to some extent. So that is why it may be good for patients. Again, if you are having comorbid anxiety or depression, if you are only having insomnia, never use antidepressants. It is good for sleep maintenance insomnia. So there are some drugs like mirtazapine, trazodone, and nefazodone. Actually, they have antihistaminic activity also. That is why it is good for sedation. And please refer the actions and areas of the above, because they also have their own range of side effects. Like nefazodone is hepatotoxic in nature, trazodone can cause priapism, that is painful erection of the penis, and trazodone has H1 receptor blocking activity also, so it can cause sedation and weight gain. A lot of issues are there. We will talk about that later. So this is sleep apnea. I will come into this in the next video. In the next video, we'll talk about sleep apnea. We have narcolepsy, lot of interesting terms. In the next video, I will be talking about that. If you appreciate my work and whatever I have said right now, if it is matching your frequency of practical knowledge hunger, then please do subscribe and share it to maximum people. Because as I said before, knowledge is power, and knowledge shared is knowledge doubled. So that's it. Tomorrow I'll come with the remaining parts of sleep disorders. So till then, it's goodbye. Take care. Study well.